please join me in welcoming my colleague, John Floras.
Thank you, Alan, for those very generous words. I have a picture. So my story begins at Oxford when I started my PhD in 1977. And I had the great fortune to join the first group in the world that was measuring beat-to-beat blood pressure in patients when they left the hospital and they went home. We did it by putting a catheter in the artery, attaching the catheter to a transducer and a tape recorder. And with a 50,000-pound floor-to-ceiling mini computer, one of the first in the UK, we were able to generate these plots of systolic, mean, and diastolic blood pressure over 24 hours above and heart rate below. But what this taught me was three things. One, when our patients left hospital, their blood pressure almost invariably dropped. And later that became known as white coat hypertension. Number two, there's extraordinary variation in blood pressure during physical activity, during work, during emotional activity. So it became clear that the brain was extraordinarily important in regulating blood pressure. And number three, you can see this gentleman had an afternoon nap and his blood pressure fell. You could see that when he went to sleep, his blood pressure was virtually normal, except when he got up twice to pass urine. And then the abrupt change in blood pressure when he got up. So that taught me three things about the regulation of blood pressure that I have carried on to the present day. Now, when I came to Sinai, I thought we should pivot our division's attention to heart failure, and we formed a group that almost exclusively was focused on the study of heart failure in humans. Why? Because by that time was becoming the number one cause of hospitalization and death in Canadians, particularly Canadians over the age of 65. And the average survival, if you were admitted to a hospital with heart failure at that time, was about 8 months, and overall about 2 years. We had very few drugs, but what we did know was one of the biggest causes of premature death in heart failure is if your sympathetic nervous system was turned on and you were releasing large quantities of noradrenaline that were affecting heart cells, that were affecting blood pressure, and were affecting the kidney. But we didn't know why that was occurring. Now, there were two forms of heart failure. At the time, we focused our attention on the heart failure that you see on the left, where the heart is damaged, say from a heart attack, from a virus, from long-standing high blood pressure, and the heart is weak. It just does not pump well. And to compensate for that, it turns on the sympathetic nervous system to increase its performance and raise the blood pressure to allow more blood to go to the kidneys and the brain. On the other side is the type of heart failure we see now more commonly in people over the age of 65. This is where the heart is affected by diabetes, by obesity, by high blood pressure. The heart gets stiff. It's pumping well, but it's not relaxing. And because it's not relaxing, it's not accepting blood from the lungs, and hence that contributes to the type of breathlessness that Dr. Mack spoke to. So in that previous picture, the heart was by itself. In these illustrations, the heart was by itself. But the heart is part of a very integrated system that is very finely controlled normally. And this is the type of schema that I've been working on over the last 30 years. On the left, you see the heart as a sensory organ. The heart senses changes in volume and pressure and sends signals to the brain. The upper chambers of the atria send signals to the brain saying, I'm full of fluid. The lower chamber, the ventricle, sends signals to the brain saying, I'm not pumping well, do something. Those signals converge on the brainstem, along with signals from the pressure sensors in the neck, the chemical sensors in the neck, the muscle exercise sensors, the stretch receptors in the lung, sensors in the kidneys that say I'm not getting enough flow. All of that converges on the brain. And when we are exercising and when we have emotional stress, input from the brain comes down to that brainstem area and it projects out signals to the heart, to the kidney, to the blood vessels, to the adrenal glands saying, I need more blood pressure, I need more heart rate. And that imbalance leads to premature death in heart failure. So how do we understand this? Well, Gary Newton and John Parker developed the capacity to look at the amount of noradrenaline the heart is exposed to and the kidneys exposed to. They did that in the cath lab and did pioneering research in the 90s and 2000s. My interest has been on tapping into the nerve that allows us to stand up, the nerve that goes from the brain to the blood vessels in the legs. And that's what I've emphasized here with the circle. When those blood vessels constrict, the heart has to push harder in order to work. So I brought to Canada, after going to Sweden and the US, the technique of measuring the nerve activity by putting a tiny microelectrode into that nerve. And we were the first in Canada to do that. And here's an example, if the video starts, of a healthy young woman, athletic young woman. And this is the type of activity that we pick up in the laboratory. So each time that nerve fires, a quantum of norepinephrine is released and the blood vessel constricts. And in this healthy young individual, only 1 in every 6 or only 1 in every 7 heartbeats is accompanied by one of these bursts of sympathetic activity. So you can hear this, you can see this. So this is what the brain is telling the blood vessel to do. Constrict, but not that much. Now, when we went on to patients with heart failure, we found tremendous variation, but of concern, we found almost every heartbeat activated a burst. And we heard these remarkable pulse synchronous bursts of sympathetic activity. And so the heart is being bathed with norepinephrine in toxic quantities. The kidneys are being bathed with norepinephrine, and they're holding on to salt and water, and the blood vessels are constricting, making it harder for the heart to work. And so we can couple these recordings along with now continuous non-invasive measures of blood pressure. We don't have to put catheters in. We can have plethysmographic digital measures of blood pressure by laser. And we have that with the heartbeat. And we have the raw signal that we can pull out additional information, but we can see that this is the type of individual who we know statistically has a high probability of passing away. So Mark Badroff, my fellow during COVID, assembled systematically 658 normal individuals from our lab in blue and heart failure patients in pink. And we see that about 50% of our heart failure patients have activation of the nervous system. And we have systematically identified over the last 20 years why this occurs. We looked at all the systems on the left and seen why they would be deranged in heart failure and how we might then modify things. Now, but this is all at rest. What happens when we exercise? And exercise is important because heart failure patients are fatigued when they exercise. They get breathless. We asked, what is the nervous system during exercise? And no one had done this before, but we developed the capacity to measure the nerve activity during exercise. So on the left, we have the exercising leg, and on the right, we have the nerve firing. And so if I just start the video, you can see that we have a stable signal here in this individual in the lab during exercise. And that allows us then to look at what happens to blood pressure, heart rate, and the nervous system during exercise. And what we found was that in a heart failure patient, there's a paradoxical increase in nerve activity. You don't see this in a healthy individual. It goes down, and the more it goes up, the more norepinephrine release, the less the individual can exercise, the less oxygen they can take up, and that's what the graph represents on the left in heart failure, as opposed to the right in normals. And recently, Mark Badroff, my scientific associate, presented these data in Chicago, showing that the same thing occurs in the far right in patients who have preserved ejection fraction. These individuals are particularly incapable of exercise because they get short of breath. And part of that, in our view, is that the nervous system is constricting the blood vessels. The leg is not getting the blood flow it needs. It's not getting the oxygen, and exercise is compromised. Now, we are then working with other groups on the concept that we can modify this sympathetic outflow. Our focus is on exercise rehabilitation. The work that I did on the baroreceptors has led to a device which you can use in the upper right to stimulate the baroreceptors. That's being tested now in the United States and is being reimbursed. We are now working with industry to look at stimulation of the vagus through the tragus. I've always wondered why my dogs enjoyed me scratching that part of the ear. But that part of the ear actually has afferent nerves to the heart that this part of the ear doesn't have right here, but there's devices now that you can stimulate in order to modify heart function. We want to test that. And with Dan Franklin at the U of T, we are looking at wearable patches that can allow us to get the type of blood pressure measurements that before required the intraarterial catheter. But I just want to close about sleep, because this is a very important part of our program here. In the early 90s, when new drugs came out for heart failure, I gave them, and 3 of my patients died, all men. I went to the funerals, spoke to the widows. They all died in their sleep. And one of them said, "Why was my husband drowning? Should I have learned CPR?" And I asked why she said that, and it was clear that something was happening to her husband's breathing at night. And that prompted me to talk to my colleague Doug Bradley, who ran the sleep lab. And we then measured the next 450 heart failure patients at Sinai and UHN. And we did the first study in the world on the far left, showing that 37% of our patients with heart failure had obstructive sleep apnea, and 33% had central, where your airway doesn't obstruct, your brain is not regulating carbon dioxide, it's not sensing it right, you just stop breathing. And it turned out those were the patients that died. These were the patients from our clinic. And we found that if you had mild or no sleep apnea and you were followed for 6 or 7 years, you had very good survival. But if you had sleep apnea, you had premature death. And so we embarked upon a series of studies. We showed in research on the 16th floor that if you treated this obstructive sleep apnea for 1 week, you got more of an increase in heart function than you did with any other drug. We then assembled 11 centers in Canada and in Germany, and with funding from the CHR, we did the first study of treating central sleep apnea. The device called CPAP did not work. It was very ineffective, and half the people had no impact on mortality. But a newer device came along. It's an adaptive sort ventilation. It's like a little computer that controls your breathing. If your breathing stops, it senses that and pushes ventilation. If you're breathing, it holds back, and you don't have to ventilate. And this device treats both obstructive and central sleep apnea. And with support from the CHR, we started the largest trial in the world. We recruited all of our fellows, former fellows from Brazil, from Japan, from Italy, from France, from Germany, and we had centers in Spain and the UK, so 9 countries, colleagues in the US, 49 centers, and we were able to randomize 741 of our patients. We wanted 860, and guess what happened? 3 things happened. A primitive device by another company was found to actually overventilate people because it had the wrong algorithm and caused more cardiac death. So we had to stop the study for 1.5 years until everyone was reconsented and said this is a different device. Then COVID hit us, and all the sleep labs around the world were shut down. And then we said, well, we'll continue to follow these people. And what happened then was that the device by Philips had a major fault leading to the insulation on the motor breaking down. So the FDA recalled the devices, so we had to stop. But we were able to study those 731 patients, and we found no impact on mortality overall or with obstructive sleep apnea, but central sleep apnea in blue, patients seemed to have a better outcome. We were underpowered, but it's exactly the proportion that we thought would occur. And for the first time, we showed that treating sleep apnea and heart failure can improve sleep quality, REM sleep, heart failure symptoms, and quality of life. So this is particularly evident in central sleep apnea. So this is very encouraging. This was data that I think will then lead to a change in the guidelines worldwide. Right now, there's a real reluctance to treat central sleep apnea because of that earlier trial with a device that overventilated patients. We never had a safety signal. And there was ambiguity about whether or not to treat obstructive sleep apnea. $14 million later, with the support of CHR, industry, and donors in the room, we were able to complete the study, and we're going to be changing guidelines for treating heart failure worldwide. So we thank you for your support.